I'm Jim Richards. I'm Professor of Biomechanics here at the University of Central Lancashire, and I'm the research lead for the Allied Health Research Unit. So within our lab and within our research unit here, we look at many varied conditions and pathologies. We have got a wide range of different research themes, which go from anything to do with musculoskeletal through to neurological conditions, and also an area which is very much growing within our research is looking at devices that interact with the body. And one of the aspects that we're going to be talking about today is the use of bracing in dealing with knee instability. So the systems we use to analyze the effect of the bracing are a 10-camera infrared movement analysis system, which is a Qualisys system, a 4 force plate AMTI system, which we then link with the Qualisys system, and then we can also study the EMG or the electromyography from up to 16 muscles with a DELSYS EMG system. So combining all this information, we can work out the dynamic angles and the dynamic changes in all the different planes, but we can also work out the moments and how the muscle activity also change in all the different directions and all the different planes. One of the other conditions where bracing has been shown to be effective and useful is with people who have suffered anterior cruciate ligament rupture or ACL rupture. Up to 250,000 people in the US each year suffer an ACL rupture or ACL injury. So the main risk factors when somebody is getting an ACL injury are either when their knee is in full extension, or when their knee is in internal rotation or in a valgus position. In other words, when the knees are more knock-kneed, if you will. Now, when we're thinking about the ACL loading, we need to think about the ground reaction forces. So when somebody is landing, you have a ground reaction force coming out of the ground, and this has got a vertical and a horizontal component. The horizontal component, we can have an anterior component of the ground reaction force. This anterior component can cause an anterior draw on the tibia, on the femur. And this anterior draw is the thing that causes this strain on the ACL. The challenge to the stability of the knee with the absence of an ACL or with a compromised ACL means that we're going to have this anterior draw or anterior movement of the tibia on the femur, or we could call it a posterior movement of the femur on the tibia. So to control this or to give stability back to the knee, we need a posterior force directed on the tibia as close to the knee as possible, and we need an anterior force on the femur, again as close to the knee as possible, to create this anterior stabilization. So by having these two forces as close to the knee as possible, this then replicates the force in the ACL. However, if we're going to have these two forces, we need two additional anchor points. One on the calf, so we need a calf anchor point, which is going to be more distal to the knee, and we also need an anchor point on the thigh, and this needs to be more proximal to the knee. So together, these give us our 4 points of force system. In addition to the issues with the anterior draw and the loading in the ACL, the position of the knee is also very, very important. And it's been shown that as the knee approaches to full extension, then there's a greater risk factor for the ACL injury. So what we require from an ACL brace is a hinge which buffers or does some shock absorption and prevents the knee getting into full extension. In preventing the knee from getting in full extension, then we are protecting the knee by increasing the involvement of the quadriceps and the hamstrings.